bacterial pathogens causing meningitis, bacterial meningitis. And there are some less common in specialized subpopulations of the patients. For example, Listeria monocytogenes, especially in two extremes of ages, neonates and more than 50 years old and immunocompromised. Group A beta hemolytic streptococcus, Group B beta hemolytic streptococcus, gram-negative RARS, and Mycobacterium tuberculosis. There are a few other, apart from bacterial, there are viral causes and fungal causes, but today we'll be focusing only on the bacterial causes, which are commonly known as pyogenic meningitis. We will leave aside Mycobacterium tuberculosis, and we will focus on these microorganisms, bacterial microorganisms, in today's lecture. Antibiotic treatment of pyogenic meningitis. Okay. So causative organisms, you need to memorize them religiously. Keep in mind, because this table is so important for you to memorize, because based on this information, you have to decide the empirical management. I told you already, this is a medical emergency. You can't wait for the definitive diagnosis or definitive etiologic agent to know to start treatment. You have to start treatment right away as soon as you suspect a case of pyogenic meningitis. So in that case, you have to cleverly choose an antibiotic, and that choice of antibiotic depends upon your knowledge of epidemiological and pattern of infections in various age groups and various risk factors and various predisposing factors. So you have to memorize this list religiously, because this is very, very important. For example, if I can ask you a question in a certain subset of a patient suffering from meningitis, you suspect what will be the empirical treatment. You won't decide about the empirical treatment unless you know the potential microorganisms that might have caused this infection. So, okay, let's start. Neonates and infants of less than 3 months, the most common cause is Streptococcus agalacticae. I will tell you the reason later on why. E. coli, Streptococcus pneumoniae, Neisseria meningitidis, and Listeria monocytogenes. These are the common causes of meningitis in this age group of less than 3 months. You have to know this. Second subgroup, age 3 months to 18 years. There are 3 main causes of meningitis: Neisseria meningitidis, Streptococcus pneumoniae, and the new one here is Haemophilus influenzae. From 18 to 50 years, there's very little chance of Haemophilus influenzae causing meningitis, and there are 2 only remaining: Streptococcus pneumoniae and Neisseria meningitidis. In elderly patients more than 50 years, Streptococcus pneumoniae, Neisseria meningitidis, and once again Listeria monocytogenes, which was here in the neonates and infants, which again came, and then once a new type of microorganisms has come into the picture, which is aerobic gram-negative bacilli in this age group of elderly more than 50 years. So apart from these age groups, you have to give due account to various risk factors like immunocompromised patients. You will note the bacteria causing meningitis in immunocompromised states are the same as the one which are causing the infection. Sorry, what is happening? In elderly people, Streptococcus pneumoniae, Neisseria, Listeria, and aerobic gram-negative bacilli, the same one, are in immunocompromised patients. No difference. And then the people who are undergoing neurosurgery, intracranial manipulation, including neurosurgery, Staph aureus is the one which may cause meningitis in this subset of the people. Coagulus negative staphylococci, aerobic gram-negative bacilli, and on top of that, the most important, including Pseudomonas aeruginosa. This may cause infection in people who had undergone some intracranial manipulation like neurosurgery. So this you have to keep in mind. Any question from this list? No? Dead bodies. Are you alive?
Yes, doctor. No
Robert is
question
alive.
till now.
Okay, thank you.
Doctor, it was clear. Thank you.
Okay, thank you. Now, I'm not a microbiologist, but few things based on some gram staining and other things you have to know about the microorganism. Just one slide each for important microorganisms. Neisseria meningitis, gram-negative aerobic cocci, 5 to 15% asymptomatic nasopharyngeal colonization in population, and transmission by air droplets, kissing, sharing saliva, and it is common cause of meningitis in children and young adults with overall mortality rate of 3 to 13%, and it happens more often in crowding situations like military recruits, college dormitory, and in Hajj. That is why the Saudi government has made it mandatory for every Hajj aspirant to have immunization with Neisseria before coming to Hajj. And then Streptococcus pneumoniae are also known as pneumococcus. Gram-positive diplococci, most common cause of bacterial meningitis in the US with mortality rate of 19 to 26%. Haemophilus influenzae, gram-negative coccobacilli, meningitis usually seen in children less than 6 years. Do you remember the second group? 3 to 18 years. Meningitis in above 6 years usually associated with sinusitis, otitis, pneumonia, sickle cell disease, splenectomy, diabetes mellitus, alcoholism, immunodeficiency, or head trauma with CSF link. Mortality is usually 3 to 6%. Listeria monocytogenes. This is gram-positive facultative anaerobe. May be isolated from dust, soil, water, sewage, and decaying vegetable matter. It is usually a foodborne infection with contaminated coleslaw, raw vegetables, milk, and cheese. And it is most common, as I mentioned in the previous slide, in neonates and elderly, and in some immunocompromised alcoholics malignancy. And mortality rate in this case is 15 to 20% with Listeria. Streptococcus agalacti, do you remember in which population this infection is quite common? Rather most common? Does anyone remember?
Newborn.
Newborns. The reason? The reason? It's a gram-positive.
Because of the birth canal.
Yes, because it is asymptomatic vaginal or rectal colonizer in 15 to 35% of pregnant women. So there's a vertical transmission from mother to fetus in newborn. That is why it is the most common cause of bacterial meningitis in neonates. Most common in newborns, mostly vertical transmission, but some horizontal transmission from the hands of nursery personnel. Is that clear now? Why it is common in newborns? Aerobic gram-negative bacilli, increasingly important cause of bacterial meningitis, Klebsiella, E. coli, Serratia, and Pseudomonas. Sorry, let me take this. Other lecture, lecture. and Pseudomonas aeruginosa, usually after head trauma or neurosurgery, may be seen in neonates, elderly, and immunocompromised patients, as I mentioned already in the initial table. Now, I gave you the information about the potential etiological agents in various subpopulations. I gave you the brief background about the microorganisms, some microbiological characters. Now, how to treat patients with meningitis. We'll discuss this pharmacotherapy of meningitis under 4 headings: antibiotics, anti-inflammatory, agents to decrease intracranial pressure, and anticonvulsants if needed. We'll discuss these 4 subheadings one by one. Let's start with antibiotics. Now, principles of antibiotic therapy are, first of all, prompt initiation of treatment. You have to right away, as soon as you suspect a case of meningitis, don't wait for the further reports. Right away start the empirical treatment of meningitis. You have to choose mainly bactericidal agents with adequate CSF levels. And empirical treatment based on age and predisposing factors, as we discussed already. And as soon as, after you started the treatment, as soon as the reports are available and you are able to identify the definitive microorganisms based on the investigations, you have to narrow down your antibiotic therapy. So you have to imply, as soon as possible, a specific treatment based on gram stain or other investigations. So empirical treatment and specific treatment we will discuss one by one. Before that, you won't be able to imply empirical treatment if I don't revise the antibiotics which we discussed in POD blog, especially the cell wall synthesis inhibitors and aminoglycosides. Do you remember the cell wall synthesis inhibitors? What are the antibiotics which come under this class? Anybody?
Beta-lactams?
Beta-lactams, very good. And others?
Penicillin.
Penicillin is beta-lactam.
Oh, yeah.
Cephalosporins.
Cephalosporin is also beta-lactam.
Vancomycin.
Vancomycin, very good. So we have beta-lactam antibiotics and vancomycin, which is not beta-lactam. So beta-lactams are again divided into various classes. Cell wall synthesis, all are important in the context of today's lecture. Beta-lactams and vancomycin, 2 classes. So beta-lactams are divided into 4 subclasses: penicillins, cephalosporins, carbapenems, and monobactams. Cephalosporins are further subdivided into 5 generations, 1st to 5th generations. So we'll just briefly, not in detail, not side effects, not many things, just we will focus in the context of today's lecture, just the antimicrobial spectrum of all these antibiotics, and then you will be able to employ empirical management based upon your knowledge of the potential microorganisms causing meningitis, your knowledge of the antimicrobial spectrum of the antibiotics. Then you can mix and match the antibiotics in particular situation. Okay. Beta-lactam antibiotics, penicillins, cephalosporins, carbapenems, and monobactams. All cell wall synthesis inhibitors, beta-lactam antibiotics, they work in the same mechanism. The mechanism of action of all these beta-lactams is exactly the same, no difference at all. Cell wall synthesis, the mechanism is cell walls of bacteria are essential for their normal growth and development. Peptidoglycan is a heteropolymeric component of the cell wall that provides a rigid mechanical stability by virtue of its highly cross-linked network in the cell wall, peptidoglycan. Do you remember the mechanism of action of beta-lactams? Does anybody remember?
cell wall synthesis inhibitor.
Synthesis, okay. Vancomycin and beta-lactams both are cell wall synthesis inhibitors. Is there any difference? Because as the class of antibiotics
They target different stages of the cell wall synthesis.
Okay, good. And in case of beta-lactams, which stage is blocked?
Transcriptase.
Very good. The last step, that's the cross-linking of the peptidoglycan. Okay. So first of all, you need to understand what is peptidoglycan. Peptidoglycan, it is composed of glycan chains, which are linear strands of two alternating amino sugars, NAGE and NAME, N-acetylglucosamine and N-acetylmuramic acid. They are cross-linked together by peptide chains that makes the final structure of peptidoglycan as rigid, mechanically very strong cell wall, which can withstand the outer environment very safely and keeps the bacteria very safe. So you can see from here, NAME and NAG, these are cross-linked with these peptide bonds. This peptide bond, this networking is catalyzed. This is the final step under the influence of an enzyme known as transpeptidase, which is also known as, what is the other name of transpeptidase? Do you remember? PBP. You have forgotten everything from POD. Do you remember PBPs?
Penicillin binding protein.
Very good. PBPs, penicillin binding proteins, are nothing but the other name of enzymes, transpeptidases. They are the same. Before we knew the actual structure of transpeptidases, we knew that penicillins and other beta-lactams, they bind to a special receptor on the cell wall. We just simply call them PBPs, penicillin binding proteins. Later on, they were characterized that those are basically the enzymes, transpeptidases. The inhibition of those enzymes is helpful in inhibiting the cross-linking between the peptidoglycan molecule, so the cell wall synthesis is inhibited. So it is the last step in peptidoglycan synthesis that is inhibited by all beta-lactams, penicillin, cephalosporins, and the remaining two classes. Beta-lactams bind to active site of the transpeptidase enzyme, as I mentioned, PBPs, that cross-link the peptidoglycan strands and irreversibly inhibit it. Last step. Eventually, the growth of the bacterial cell wall is inhibited. So the first class is penicillins, natural penicillin, benzyl penicillin, or we call it penicillin G, effective against gram-positive cocci, anaerobes, and selected gram-negative rods. Penicillinase resistant penicillins. What is penicillinase or beta-lactamase? What is penicillinase or beta-lactamase? It is an enzyme synthesized and released by some microorganisms, especially the gram-negative and some staphylococci, which can break down the beta-lactam ring of the beta-lactam antibiotics. And in the absence of beta-lactam ring, within the beta-lactam antibiotics, the drug ceases to be an antibiotic. It is no more an antibiotic because in order to exert antibacterial activity, the drug must be having an intact beta-lactam ring in that class. So penicillinase resistance penicillins are the ones which can withstand the enzymatic action of beta-lactamase or penicillinase. And we have two drugs in this class, napsilin and oxacillin. They can resist the action of penicillinase, especially the staphylococcus. We are not talking about MRSA. We are talking about the penicillinase producing Staphylococcus aureus. Is there any intelligent student in the class who can tell me what is the difference between penicillinase producing Staph aureus and MRSA? Anybody?
I think the penicillinase, just that they had a new enzyme that will break down the penicillin.
Very good.
However, in MAFA, you change the binding site, you change
Very
the
good.
penicillin binding.
Bravo. Excellent. So what happens is, Staph aureus, some strains of Staph aureus, they just produce enzyme beta-lactamase or penicillinase, which can hydrolyze the beta-lactam ring, and the antibiotic is no more effective. Number one. There's another mechanism of resistance within the Staph aureus, where we call it MRSA, methicillin-resistant Staph aureus, whereby they do not secrete penicillinase. Rather, they change the structure of the PBPs. So the PBPs now, they do not provide a binding site for the beta-lactam antibiotics. In that way, the bacteria become resistant to almost all the beta-lactam antibiotics. Because beta-lactam antibiotics require binding with transpeptidase enzyme or PBPs. If the structure of that receptor is altered, beta-lactam antibiotics are unable to recognize the binding site and they will be rendered ineffective. So mechanism of resistance in Staph aureus, two types. Let me summarize. One, secretion of beta-lactamase, and other, changing the structure of PBPs. Changing the structure of PBPs is the underlying mechanism of resistance of MRSA, methicillin resistance Staph aureus. Clear? Any question? Good. We have other penicillins, amino penicillins, not important in today's lecture, but anti-pseudomonas, not important. Cephalosporins, we have 5 classes of cephalosporins. First generation, effective against gram-positive and few gram-negative, E. coli, Klebsiella, and Proteus. Second generation, effective against some gram-positive and some gram-negative. Third generation, very important in the context of today's lecture, ceftriaxone and ceftazidime. These are 2 prototype drugs. They are effective against, they are broad spectrum, effective against many gram-positive and gram-negative cocci like Neisseria, plus many gram-negative rods. However, please keep in mind, this is very important. This will come also later on under discussion, that within the third generation cephalosporin, there is only one third generation cephalosporin drug, ceftazidime, which also covers Pseudomonas aeruginosa, not others. All third generation cephalosporins, there are many, at least 8 to 10 third generation cephalosporins. Among them, only one ceftazidime covers Pseudomonas aeruginosa. That is why I have highlighted it in red. And there's fourth generation, which are comparable to third generation, but greater activity against gram-positive and Pseudomonas. And fifth generation, lot of activity, but no activity against Pseudomonas aeruginosa. We'll focus mainly on 2 classes, third and fourth generation, in the management of meningitis. Just keep in mind, ceftriaxone, ceftazidime, third generation, and cefepime, fourth generation, cephalosporin. And carbapenems, imipenem, meropenem, okay, vancomycin. This is non-beta-lactam antibiotic. The mechanism of action of this antibiotic is different from the beta-lactams. How? It inhibits bacterial cell wall synthesis by inhibiting peptidoglycan polymerization, which is a step earlier than that of inhibited by beta-lactams. So beta-lactams inhibit the cross-linking of peptidoglycan, whereas vancomycin inhibits the polymerization of peptidoglycan, one step before that. Effective against MRSA. Why effective against MRSA? Can anybody explain?
Because it doesn't affect, it is not affected by changing the binding protein.
Very good. So it does not require, vancomycin does not require the presence of PBPs to bind and act on the cell wall. So it is, the target is different. So even though it is methicillin resistance staphylos, PBPs have completely changed, still they will be susceptible to vancomycin because the target is different. This time the target is not PBPs or transpeptidase. So it is not absorbed from the GIT and is given as an intravenous infusion. Keep in mind, effective mainly against MRSA. I have highlighted it. Finally, aminoglycosides, gentamicin, tobramycin, amikacin, bactericidal against many gram-negative. Keep in mind, I have highlighted gram-negative. They diffuse through porins of gram-negative bacteria and enter periplasmic space, bind to 30S ribosomal subunits, and interfere with the initiation complex so that no further initiation can occur. They also slow down protein synthesis that has already initiated and induce misreading of the messenger RNA. So we discussed beta-lactams and vancomycin, which come under the broad class of cell wall synthesis inhibitor. Regarding aminoglycosides, which class of antibiotic does this class belong to?
Protein synthesis.
Protein synthesis inhibitors. Pharmacology, these drugs are not absorbed from the GIT due to their highly polar and polycationic structure and are given by intramuscular or intravenous injections. Cerebro CSF penetration is poor. Keep in mind, I have highlighted this. All these things which I have highlighted are the points of discussion in the coming slides. Now, empirical treatment. Now you know the potential etiological agents in various populations. Now you know the antimicrobial spectrum of various antibiotics. Now just mix and match and rationalize. First of all, neonates. The same table, common pathogens, Streptococcus agalacti, gram-negative, E. coli, Klebsiella, Enterobacter, Proteus, Streptococcus pneumoniae, Neisseria, and Listeria monocytogens. As soon as you suspect a neonate with meningitis, right away start empirical treatment with ampicillin and a third generation cephalosporin or ampicillin plus an aminoglycosides. Why aminoglycosides? In the previous slide, I mentioned that the CSA penetration is poor. Rationalize. Is there a smart student in the class who can rationalize this combination? Empirical treatment? Anybody?
I think I have a theory. So with empirical treatment, we want to mainly look for a drug that has excellent CNS penetration, as well as a wide range. And then we want it to, by wide range, I mean it covers a wide range of bacteria that could cause meningitis.
Okay, wide range in the context of this neonate, we have these microorganisms. Just cover these, just mix and match. Ampicillin against what? Third generation cephalosporin against what? And aminoglycoside against what?
Aminoglycoside is for gram-negative.
Okay, so these will be covered, gram-negative, Enterobacter, E. coli, Klebsiella, and this one. And what about ampicillin? Ampicillin for what?
Gram-positive.
Gram-positive, mainly Streptococcus agalacti, and then also against Listeria monocytogens. It is very effective. Ampicillin against Streptococcus agalacti and Listeria monocytogens. And third generation cephalosporin, it is also effective against gram-negative as well as against Streptococcus pneumoniae and Neisseria meningitis. Just, do you want me to go back to the previous slide of antimicrobial spectrum of third generation cephalosporin? Both gram-positive and gram-negative are susceptible to third generation cephalosporin, but here in case of Streptococcus, it is not susceptible to third generation. Also Listeria, which is anaerobe, it is not susceptible to third generation cephalosporin. So you have to give, so at this stage, you don't know neonate, what is the causative organisms among this list. You have to cover all possible causes. So you have to give empirical treatment, which can cover all possible causes. So you give either ampicillin, a combination of ampicillin and a third generation cephalosporin, or ampicillin plus an aminoglycoside. In the previous slide, I mentioned that aminoglycoside, they have poor penetration in the CSF. Then why would you give here along with ampicillin? If you remember my lecture in POD last semester, in the first lecture, very first lecture on terminology, pharmacological terminology, I mentioned a term, synergism. Does anybody remember? Drug synergism. When more than one drug, when two drugs are given together, the outcome is entirely different. The combined effect of two drugs, when given together, is more than the mathematical sum of the two drugs given separately. Do you remember the definition? 1 plus 1 is equal to more than 2. So ampicillin and aminoglycoside have synergistic effect, even though aminoglycosides have poor penetration, but even in small quantities, because of the synergism with ampicillin, they can exert a bactericidal effect against gram-negative bacteria. Very effective against gram-negative. So in this situation, you have to initiate treatment with either ampicillin and third generation cephalosporin or ampicillin plus an aminoglycoside. Clear? Let's move to second. Infants and children 3 months to 18 years. 3 classes: Neisseria, Streptococcus pneumoniae, and Haemophilus influenzae. A third generation cephalosporin plus vancomycin. Rationalize. Anybody? Nobody? Okay. Third generation cephalosporin is effective against all 3. But because this is empirical treatment, we don't know. There are many strains of Streptococcus pneumoniae, which are resistant even to third generation cephalosporins. So in that case, you add vancomycin before you actually know the sensitivity report after the culture and sensitivity. Then you can remove vancomycin later on. But since it's a medical emergency, you will start with a combination of third generation cephalosporin and vancomycin together. 18 to 50 years, Neisseria and Streptococcus pneumoniae, same thing, because third generation cephalosporin is effective against both, but still on the safer side, you will add vancomycin because you never know that this particular step is sensitive to third generation cephalosporin or not. No. Okay, age more than 50 years. The common pathogens: Streptococcus pneumoniae, Neisseria, Listeria, and aerobic gram-negative bacilli. The treatment of choice, empirical treatment, is vancomycin plus ampicillin plus a third generation cephalosporins, 3 antibiotics. Now you should be able to rationalize this combination of 3 drugs. Can you? Third generation cephalosporins against pneumoniae, strep, Neisseria, and aerobic gram-negative bacilli, ampicillin against listeria, and vancomycin on the safer side. It is possible that Strep pneumoniae may be resistant to third generation cephalosporin. Clear? At least respond that you are listening and you are understanding what I am saying.
Doctor. Yes, doctor.
Yes,
Please.
doctor.
Okay?
Doctor,
So third generation cephalosporin for gram-negative, Neisseria, Strep pneumoniae, ampicillin for listeria, and vancomycin for the safer side, to be sure. So basically, immunocompromised and more than 50 years are the same thing. Okay. Post-neurosurgery, the common pathogens causing post-surgery meningitis are gram-negative bacilli, including Pseudomonas aeruginosa. Here you have to cover Pseudomonas aeruginosa, Staph aureus, and Staph aureus. Now see, vancomycin plus cefepime or vancomycin plus ceftazidime or vancomycin plus meropenem. Why? Rationalize.
A different mechanism of action.
Why vancomycin to cover what and cefepime to cover what?
Vancomycin for MRSA.
So okay, Staph aureus. Okay, here Staph aureus. And what about
Meropenem for
why cefepime?
Pseudomonas.
What is cefepime? Do you remember?
fourth generation.
Fourth generation. Why we selected fourth generation here instead of
Positive gram
third
positive.
generation?
For positive and negative.
Anti-pseudomonas.
Oh, third generation in the previous slides, everywhere, we selected third generation. Here we are selecting cefepime. Fourth
Pseudomonas.
generation. Because of Pseudomonas. Didn't I tell you in the antimicrobial spectrum of cephalosporin that fourth generations are highly effective against Pseudomonas? And cefepime is the representative fourth generation cephalosporin.
Doctor, isn't it ceftazidime?
Ceftazidime is the third generation, but only one third generation cephalosporin which is effective against Pseudomonas. So
Okay.
either you will go for the fourth generation to cover all the gram-negative, vancomycin to cover Staph, or alternatively you will go for the vancomycin to cover Staph and ceftazidime, which is a third generation, only one third generation cephalosporin. So I haven't mentioned, keep in mind, in the previous, everywhere I have written here, third generation. Here I haven't written third generation. I have written a specific drug, ceftazidime. Okay, let me go back to the slides. See. See here. Did you see here? I made it red. Ceftazidime is the one drug within the third generation. There are many third generations which is effective against Pseudomonas. And fourth generations are routinely effective against Pseudomonas. So in this particular case, instead of writing a third generation cephalosporin, I specifically mentioned ceftazidime. Not all third generation cephalosporin. Within the third generation group, only ceftazidime because you have to cover Pseudomonas. And within that class, it is the only drug which can cover Pseudomonas. Is that clear now? Hello?
Yes, doctor.
Okay. Vancomycin plus another imipenem compound, beta-lactam meropenem, which is also effective against Pseudomonas. So there is a rationale for choosing empirical treatment in these populations of patients. Now, once you implant empirical treatment, and after 2 to 3 days, you got the idea of the specific etiologic agent, you have to modify your treatment accordingly. A specific antibiotic. For Streptococcus pneumonitis, Vancomycin, a third generation cephalosporins. When you receive the culture sensitivity report, third generation cephalosporin is effective, you can remove vancomycin. Neisseria, third generation cephalosporin. Listeria, ampicillin. Streptococcus agalacti, ampicillin. Haemophilus influenzae, third generation cephalosporins. So you can trim down the combination from empirical treatment once you receive the report, culture report, only single drug, narrow down your therapy to one single drug. E. coli, third generation cephalosporin. Pseudomonas, cefepime or ceftazidime. Are they either fourth generation or this specific drug from the third generation? And on the right side column, I mentioned the alternative drugs. Forget about the alternatives. Now, Staph aureus, if it is methicillin susceptible, there are one class of drugs which I mentioned in the subclass of penicillin. Say, penicillinase resistance. Do you remember? Nepsilin and oxacillin. These are the drugs which will be given in the Staph aureus infection, which is not MRSA. Which is not MRSA. If it happens to be MRSA, then it has to be vancomycin. Because the mechanism of resistance is different. Is this clear? Is this concept clear? If in Staph aureus, if it is methicillin susceptible, that means this particular is not MRSA, but it produces penicillinase, beta-lactamase. In that case, two drugs, nepsilin and oxacillin, are effective. If Staph aureus happens to be MRSA, then only vancomycin will be effective. So we discussed antibiotics. Now anti-inflammatory. Dexamethasone before or with first dose of antibiotic decreases subarachnoid space inflammatory response to antibiotic-induced bacterial lysis. So you have to give along with or even before the first dose of antibiotic. Significant reduction in deafness in pediatric H. influenzae and pneumococcal meningitis, because this is a long-term complication in this H. influenzae and pneumococcal meningitis, especially in the children. In adults, for patients with evidence of cerebral edema, so in order to reduce anti-inflammation, inflammation, you have to give dexamethasone, which is which class of drugs does this belong to? Dexamethasone?
Corticosteroid.
Glucocorticoid, corticosteroid. Good. So the third class is agents to decrease intracranial pressure. We have only one drug in this class, which is mannitol. We will learn more in detail about mannitol in renal block next year. Briefly, it is an osmotic diuretic that is not reabsorbed. It is given intravenously. It is not reabsorbed, causes water to be retained in the tubules, and promotes a water diuresis. Since it is an osmotic agent, it exerts osmotic pressure. Since it is filtered in the glomerulus, and then it is not reabsorbed, does not come back. So it is retained in the tubules. Based on that property of being there physically within the tubules, it retains water. So it is hyperosmolar agent that makes the intravascular space hyperosmolar to the brain and permits movement of water from brain tissue into the intravascular compartment. So the fluid is sucked from the brain tissue to the vascular compartment and eventually leads to decrease in intracranial pressure. Because intracranial pressure is also determined by the amount of fluid present in the interstitial space of the brain tissue. Last, anticonvulsants, if needed. Diazepam, because some patients, especially the children, they develop seizures because of the meningitis. If the seizure is there, then you can administer benzodiazepines like diazepam, lorazepam. They can be administered if patients develop seizures during the disease, if needed, otherwise not necessary. Now, whatever we learned, let's test what have you learned. I have prepared a case scenario. A 67-year-old female presents to the emergency department with a 3-day history of worsening confusion and somnolence. Prior to this, she also complained of headache and stiff neck. She is type 2 diabetic, for which she is taking oral anti-diabetic medicines. On examination, it is not one examination, sorry. On examination, the lady was found to be in acute distress, blood pressure of 88/62 millimeters of mercury, pulse 122 per minute, respiratory rate 20 per minute, temperature 38.8 Celsius, positive neck rigidity. Her blood samples were sent for culture and CSF was obtained for examination and gram stain. Is everything clear? Look at the age, comorbidity, clinical presentation, everything. There are few questions. A presumptive diagnosis of bacterial meningitis was made. Before the availability of reports of CSF, gram stain, and blood culture, how would you manage this patient? Tell me. The last 1 hour, 40 minutes we have been discussing. How would you manage?
Empirical therapy by Vancomycin and third generation of cephalosporin.
Very good. Only
Dexamethasone.
dexamethasone. Okay, one thing. First of all, identify that she is an elderly lady, more than 50 years, and potentially immunocompromised due to diabetes. Therefore, she requires prompt treatment. Before initiating empirical treatment, let's review the potential microorganisms which
Listeria,
might cause listeria.
ampicillin,
Yes. Very good. What are the potential etiologic agents? Neisseria, Streptococcus pneumoniae, Listeria, and gram-negative bacilli. These are the possible organisms which might cause infection in this patient. So once again, what would you give? What did you say? Say it again.
ampicillin,
Ampicillin for Listeria.
listeria,
Okay. For Strep and Neisseria and aerobic gram-negative. Listeria will be covered by ampicillin. What about Strep, Neisseria, and gram-negative bacilli? Third generation cephalosporin. If Strep pneumoniae is resistant
Strep
to
can be covered by
Pilus
if
vancomycin.
it's resistant to
Now
yeah.
at this stage, you don't know the sensitivity pattern. So this is serious situation. You have to cover everything. So you have to give ampicillin, you have to give third generation cephalosporin, and you have to give vancomycin. All of them. Later on, gram stain of the CSF revealed presence of gram-positive diplococci. In that case, will this report guide you to modify treatment? If yes, how? When you got report of gram staining, gram-positive diplococci, what does this mean? Gram-negative are out? Out?
Yes.
Gram-positive diplococci means which organisms?
Streptococcus pneumonia.
Streptococcus pneumoniae. So in that case, is there any need for ampicillin here?
No.
Is there any need?
No.
Is there any need?
No.
Third generation will be still needed because Streptococcus pneumoniae are very effective. Now, in that case, you will give third generation cephalosporin plus vancomycin. 2 days later, as soon as you will receive the report of the culture, if the report says that the organism is sensitive to third generation cephalosporin, you will also remove vancomycin 2 days later. Now, immediately on the very first day after receiving the gram stain report, you will remove ampicillin because listeria is not there. 2 days later, if you receive the report that this organism, Diplococci, Streptococcus pneumoniae, is sensitive to third generation cephalosporin, in that case, even the need for vancomycin is not there. You will continue with a single drug, that is third generation cephalosporin. This is the way the drugs are given in the infections, from empirical to definitive treatment. Empirical based upon your, general knowledge or epidemiological pattern or possibility. As soon as you receive further information, you can trim down your management to make a definitive therapy that targeted against that specific pathogen. Any question?
Doctor, does third generation cephalosporin cover both gram-positive and negative?
Yes, they cover.
Okay, so why would we give ampicillin if third generation is already covering it?
Listeria.
Okay, so ampicillin is only listeria?
Yes, for listeria.
Thank you.
Ampicillin for listeria, as soon as you know that these are gram-positive diplococci, the last question is, will this report guide you to modify treatment? Yes, it will guide us. There is no need of ampicillin now. A third generation cephalosporin and vancomycin. 2 days later, when you receive the sensitivity report, that will also guide you to either continue with the 2 drugs or only third generation. Clear?
Yes, clear. Thank you.
Good. Okay. See you tomorrow. We have clinical pharmacology lecture session tomorrow. See you tomorrow. Thank you very much. Bye-bye.
Thank you, doctor.
Okay.
Thank you.